Other things that we can see are small bowel problems. Here is a patient with Crohn's disease. She has a lot of GI symptoms. There are thick-walled bowel loops here in the right side. They're circumferentially symmetrically thickened in the distal ileum. Sometimes you'll appreciate mucosal ulcerations. There's surrounding fat stranding, and this can go on to terrible problems of fistula formations, collections, and strictures, etc. This patient with chronic right lower quadrant pain right under her abdominal wall was this long loop of bowel, thick-walled. It went on and on and on. It continued. This was not an appendix. It has bowel signature, but it's not the appendix because it was not blind ending. We turned on it. It looks like bowel. It correlates beautifully with the terminal ileum, which is very abnormal here, causing edematous impression into the cecum. So this is Crohn's disease terminal ileitis. Another patient here presented with pelvic pain and pressure. There were a lot of GI complaints. She had had a hysterectomy, so they wanted us to take a look and see what's going on in the pelvis. There were no female organs, but here we have a very abnormal structure that has a very hyperemic wall, and we realized eventually that this was the rectum. So this was a patient with Crohn's disease and rectal involvement. Diverticulitis is a well-known cause of left lower quadrant pain, and if we suspect that, usually these patients go to CT. But it is a left lower quadrant problem. Sometimes if the patient's younger or can't have a CT, we could start with an ultrasound. They'll have this pain. They have white count, fever, sort of like an appendix, but on the other side. They can complain of constipation, diarrhea. So the problem usually starts in the distal left colon and sigmoid, where we see these diverticula and then surrounding inflammatory change. By far, most of these patients go to CT, but we could see a diverticulum once in a while. We could see surrounding edematous change. Here is one that has thickened wall. It was bulging from the bowel and had surrounding inflammatory change. And this was tender just as we poked at this diverticulum. We can see abscesses that form as a complication of the diverticulitis. In this patient, notice the very bright echogenic pericolonic edematous fat, which corresponds with this fat stranding in this patient with acute diverticulitis. We certainly can see an abscess. An abscess looks like an abscess. This one contains pus. This one with the bowel gas, the gas within the abscess shadows out, and we can't see very much beyond that. Now, sometimes you'll see lots of fluid-filled, dilated bowel loops. These can be small bowel obstructions, but sort of a late phase of bowel obstructions. Think about bowel obstruction. As the bowel obstructs, the peristalsis is trying to fight the obstruction. There's hyperperistalsis. It's not getting through. The fluid is backing up. All these secretions that are coming down from the mouth and stomach, etc., builds up. And then the gas gets burped out or absorbed or passed, and the bowel continues to fill and fill with fluid. That's the kind of bowel that we're talking about here. If it still had gas in it, we really wouldn't be able to see too much. But this is fluid, so we can see, and we know now that this very far gone, dangerous kind of situation, and we already have ascites. This kind of bowel can perforate. These patients are very sick and usually don't have much peristalsis. Here's a patient. This one was 33 weeks pregnant, and she had had some abdominal pain that was unexplained, and we had done a right upper quadrant ultrasound. She didn't have any gallstones. She came back again the next day, still complaining of this pain. We started searching further around, and we found abnormal small bowel loops. dilated loops, loops with thickened edematous valvulae conniventis, or also called plicae circularis, and debris within this bowel, very low peristaltic activity, long loops of these dilated segments, and we called a small bowel obstruction. Here's similar cases. Dilated loops filled with bowel. These loops are filled with fluid. There's a lot of them. This patient went to surgery, and sure enough, she had a small bowel obstruction, which you can imagine ultrasound can do quite well with such an abdomen. What we don't do very well with ultrasound is actually trying to find the point of obstruction, and CT does great with that. CT can track the bowel. Here we have very dilated loops coming to this point, and then beyond it, we don't have dilated loops. We look in the pelvis, loops are small. These are small bowel loops, they're not dilated. So somewhere in here is the cause of the obstruction. We call that a transition point. We can do coronal reconstructions. We see the dilated stomach, proximal bowel dilated, and then somewhere in here is the obstruction. In this case was an adhesion, an adhesive band that obstructed the bowel, and there's the non-dilated bowel beyond. So CT will show us a much larger area and be able to diagnose this better. Sometimes ultrasound triumphs in making a really good call. This patient had pelvic pain. It was chronic. She had multiple different studies and came one day for this ultrasound. Her pelvic organs were completely fine, but we noticed this unusual kind of hypoechoic structure. As we looked, we evaluated, we saw that there was peristalsis going through here. So the lumen of the bowel is here, where the green is. But the lesion here in orange, as we see, was actually in the wall of the bowel. It stayed with the bowel, but it was in the wall. We thought it might have been an endometrial implant or something, an intramural abscess, maybe even a colon cancer. And she eventually went to surgery, and this was a leiomyoma of the sigmoid wall. So this is a mass in the wall of this sigmoid. As far as lymphoma goes, we might pick up some pelvic nodes. Sometimes we can pick up something floating around in the abdomen, something that we call a pseudo-kidney sign, which is a large mass of lymphomatous tissue compressing the mesenteric vessels in the middle. That's what gives us that pseudo-kidney appearance. Here it is on CT, this large lymphomatous, these nodes blending together, this mass-like appearance, and compression of the central mesenteric vessels. So bowel lymphoma, mesenteric lymphoma can do this. Sometimes small bowel tumors can do this. Otherwise, lymphomas might be just nondescript masses in the abdomen and pelvic area. Other things that we might see are masses with ascites. Here we have peritoneal carcinomatosis. This is a large omental cake of peritoneal disease, carcinomatosis surrounded by fluid. Here's the corresponding CT where we see the ascites, and this is the tumor, the omental so-called cake, the large tumor mass of peritoneal carcinomatosis. Easy enough to just guide a needle straight into it under ultrasound to get tissue and cells.